Hello, JMIR followers. This is Dr. Jennifer Joe, JMIR Ambassador. Today, I'm interviewing Catherine Woodman, a researcher in the Department of Neurodegeneration Diseases and Gerontopsychiatry at the University of Bonn Medical Center in Bonn, Germany. Catherine's research interest lies in understanding long-term cognitive decline and cerebral dysfunction following acute systemic inflammatory events and chronic inflammation. Today, I'm delighted to be discussing Catherine's recent research publication in JMIR Research Protocols, Longitudinal Neurocognitive and Pulmonological Profile of Long COVID-19, Protocol for the CoVImmune CLIN study. Catherine, welcome.
Thank you very much for your interest and for the chance to talk about my research.
This is such important research in meaningfully understanding and supporting patients affected with long COVID. Shall we start with first discussing the syndrome of long COVID or COVID-19 long haulers? What is the syndrome?
Right, so this syndrome is an umbrella term. That should be said at the outset. It's not one thing at all. It's sort of a summatory or a collection of symptoms that can span many, many different organ systems. Long COVID starts at 12 weeks after the initial recovery from the acute syndrome. So you might have post-COVID, which would be the time afterwards, but this long COVID really starts somewhere between 2 and 3 months afterwards. You can start calling it something like post or long COVID, but it's just a provisional category at the moment because there's not enough research to understand what it really is, or if we should be talking about several different post-COVID syndromes, maybe affecting different organs. A British study did an online survey that was basically led by patients that had long COVID or post-COVID, and they indicated that many different symptoms could occur in the 7-month period that they studied these people. So I think they came up with over 200 symptoms that were reported in their study group. They listed them according to the most frequent symptoms, and the most frequent symptom was fatigue. Among other things, also a brain fog and what they call post-exertional malaise, which means they had problems with tremendous tiredness that is indescribable, just on a daily basis, even without exerting themselves, which makes it hard to even get up from a chair. They also talk about having difficulty with finding words or concentrating, which they call brain fog. In this study, they used the term brain fog. A huge and overwhelming majority of the patients also indicated that that was a problem for them months after the initial disease recovery.
So that just dovetails into the really nice points of, you've already started talking about it. What do we already know in terms of clinicians, researchers about long COVID? And then why is your research unique and important?
That's a very large question, and I hope to satisfy researchers out there that are listening to my answer. To date, almost all studies have been studying the very short-term period after COVID recovery. There's very limited information except for some epidemiological large studies that include data from before people got COVID. So you have to look at really different research types or data sets to be able to tell a whole story of long COVID. And it's going to take a lot of research from lots of people. So what we do know is there does seem to be, in terms of self-report, lots of problems with as I said, chronic fatigue. And if you're chronically fatigued, this will have an influence on your ability to do your job. This will have an influence on your ability to take in new information or do anything, learn anything. And so what is long COVID? What do we know about it? Well, we do know from lots of studies that there are certain things that seem to be very salient in certain studies of people that come to the hospital, for example, because of COVID. We know that there can be microbleeds in the brain. We know that there can be various reductions in the temporal area of the brain. For example, I can't speak too well to neuroradiological findings because it's not my specialty, but we are looking at that kind of data in our study. We do know that as far as self-reports go, there are lots of people that say within the 4 to 7 months after COVID, they still have cognitive problems, often denoted memory. I have to say that I think one of the advantages in our study is that we have a very well-defined population that is prospectively recruited. And so we're not taking people from the hospital who are there anyway because of cognitive complaint or physical complaint, but we're taking people that had that experience of COVID and trying to look at what they have very cleanly. So they're not self-selected in the sense that they're coming to the hospital with problems, but they've decided to put themselves out there to help us research this syndrome, not because they want help themselves.
Can you just speak specifically to the 3 cohort groups
Yeah.
that are being compared and why
Yeah.
you chose to divide them into the 3 cohorts that you did?
Right, there's 3 cohorts. So the first cohort of interest is the people that had COVID with a severe course of disease. Now we call it that because people may not have such a bad acute situation at the beginning of their COVID infection, and then it gets worse and worse, and then they have to go to the hospital, for example. And so we chose people that, because of their COVID infection, went to the hospital, even if it wasn't immediate. So that's how we defined that group. And that group was actually the easiest group practically to recruit because it was very clear they knew they had COVID. They knew they went to the hospital. We wanted to get a group that was simply asymptomatic. So they had COVID, but no symptoms. That was our ideal. And we had to face reality, which is if they didn't have any symptoms, they wouldn't know that they had COVID and therefore would never offer themselves up because they wouldn't even know who they were. So we did attempt to tap into the Heinsberg. So we had to expand the definition of the first group into asymptomatic / had only problems with smelling or tasting, and that's it. Because maybe they would know that they should get checked for COVID if they at least stopped smelling properly or stopped tasting things. And that was for us an attempt to find something that was as mild as possible to compare with the extreme group of severe. And the healthy controls, just to go back to that, was taking seriously the pandemic situation as it is for current healthy controls. I think I respect and appreciate all research efforts in all of the cohorts that have been researched up to now, whether they're online, whether it's self-reporting, everything has something to say about the COVID, long COVID recovery process. However, if you don't know what you can compare it to, if you're comparing people to historical norms that come from a pre-pandemic situation, you may have an artificial level of deficit in people with COVID experiences that really are pandemic experiences that all of us have. So I know for myself, in my family, we had some joblessness. We had some tremendous anxiety and worry, not because of the virus itself, but because of existential problems that came with losing a job because someone in my family worked in the travel industry. So that really affected us at home, and we felt it for a long time. And I know how it felt just to be married to somebody who is having this kind of issue. And so I know that our healthy controls are also affected in a way, cognitively, psychologically, even sociodemographically, in a way that other cohorts in the past would not have been affected. And that's why I plead for all research, as long as they can get funding for it, to try to recruit healthy controls, because they need to look at what is pandemic related and what is actually COVID virus related.
I really appreciate that explanation. Can you talk specifically about the parameters you're assessing with the 3 cohorts and why you're measuring what you're measuring?
Yes. So we're measuring things from a variety of disciplines, very specific cognitively because it's largely a cognitive study, although we're looking at lung function as well, and neuroradiological findings as well, and neurological findings as well. And we have some biochemistry as well, but it's largely a cognitive study because brain fog is not an official diagnosis. Brain fog is also not a real syndrome. It's a description that lay people can use, or people that are not psychologists might use to explain something's wrong. People are having a hard time thinking, but we need to understand what that exactly means. There's more to find out about cognitive abilities in these patients if you break down things according to cognitive modules. So in neuropsychology, we talk about different aspects of thinking, and we think about these things maybe differently than other disciplines. So there's no location of brain fog. What could brain fog be? It may be attentional processes. It may be executive functions. It may be learning problems. It may be recall problems. And these are all tied to different areas of the brain and different interconnections in the brain. And so we wanted to look at these things with a very finely tuned instrument in which we limited the amount of variance due to the examiner doing things differently, conducting things differently. It's all done based on a PC, actually touchpad PC technology, using German norms.
Given patient enrollment began in April of this year, you've already reported some of the preliminary data.
Yeah.
Can you speak to the preliminary data? And was this expected, was the data that you found within what you were expecting to find?
So I can speak to a very limited extent because we will be publishing the actual study results hopefully in the spring. So I don't want to take too much away, but I was able to report some of the preliminary information. We're still doing the data analysis, so I can't say in the end what it's really going to end up being. So I appreciate full data sets to be able to speak to that. But we are seeing differences between the healthy control group and both patient groups in paired analyses. So whether it comes to verbal learning or verbal memory, especially, but also to an extent of verbal fluency, we're seeing worse performance among those that have severe COVID compared to healthy controls, and the same amongst those that have asymptomatic or mild symptoms and healthy controls. I can't speak to the current data analysis between the two patient groups. I want to be careful about what I say and don't say for various reasons, but I also don't want to say something that ends up being wrong. So we're seeing some differences. It may be that we're surprised and that the asymptomatic group, and that seems to be kind of the trend we've been seeing in these verbal learning, verbal recall tasks, that it seems that the asymptomatic group is doing worse. And that surprised me. I have to say that is not what I was expecting. But I don't want to say that that's going to be the final result. It's just a trend we're seeing now.
Sure. This ends our interview. This is incredibly important work to inform and prepare us for the longer term impact of this pandemic. I want to say a big thank you to Catherine for sitting down with me today. To read the full article and for other great articles like this, go to researchprotocols.org. As always, be sure to follow JMIR on all of our social handles, which includes Twitter, Facebook, LinkedIn, and YouTube.